My name is Esendi Kagoni. I'm a passionate nurse, specialized in midwifery. I work at Moi Teaching and Referral Hospital in Mother and Baby as the nurse manager of reproductive health. The reason why I chose this topic is because many a times we leave a cesarean section to the doctors and surgeons, and we try to hide behind the carpet, low down when it comes to nurses and midwives in advocating or advising women when it comes to cesarean section. We are all aware, as my previous presenters have mentioned, about the maternal mortality, which in low income and middle income, where Kenya lies, is still very high. And the rate of cesarean section has risen dramatically, not only here in Kenya, not only in low income country, even in high income country. The rate is rising dramatically. The complication related to cesarean section, just to mention a few: hemorrhage, thrombolytic event, complication of anesthesia, and I'm glad I'm seeing some nurse anesthetists here. And even sometimes cesarean section can directly contribute to maternal morbidity and maternal mortality. So apart from that, with those complications, many obstetricians, many surgeons still perceive low risk in cesarean section, and they can even do cesarean section secondary to maternal preference. And there's no evidence showing the benefit of cesarean delivery for women who do not require it. The World Health Organization, that is WHO, recommends a cesarean section of 10 to 15%. If it's below 10, that is too low. If it's above 15, there's no benefit of such. At Moi Teaching and Referral Hospital, our cesarean section rate ranges between 10 to 20, so we are also a bit high. But we try to work with management to ensure that we are bringing the cesarean section low, or between 10 to 15%. That is what the WHO recommends. So if we have this knowledge on indication and outcome, it will contribute in reducing the prevalence of cesarean section. We adopted a retrospective study design. We used a data abstract form to do this study, and that was the finding. We'll focus more on the demographic, which is very key in any research. And when it comes to age, the minimum age was 15 years, the maximum age was 46 years. And the marital status, majority of the clients we studied were women who were married, but some little percentage of 0.3% were divorced. On education level, most of these clients, that is 40.4%, had attained tertiary level of education, while 1.5% had no education. When it comes to parity, we realized that 9% of women who underwent cesarean section were expecting their first child. They were primigravida. And that's where we come as nurses and midwives in preventing the primary cesarean section. Then on occupation, we noticed that 51% of clients who underwent cesarean section were housewives, while a low number were students. So in between, we had other women who are in profession. This is a presentation on the maternal and fetal indication. And the main maternal indication was previous cesarean section. And you know this cesarean section, the previous cesarean section usually comes about when a woman has her first or second or even third cesarean section. That was at 43.8%. And the list was maternal request. And that was one client out of 384 clients who we studied had an indication of maternal request, another indication. When it comes to fetal indication, the fetal distress, which is non-reassuring fetal status, amounted for the most cesarean section indication, that is at 43.8%, followed by malpresentation like bridge, and this is just a pictorial presentation of the same. The immediate maternal complication was hemorrhage. However, majority of these women did not experience any maternal complication. 83.3% had no immediate maternal complication, but hemorrhage was 13.6%. My previous presenter have mentioned about hemorrhage causing increased morbidity and mortality. So even in cesarean section, this is an important contributor. When you look at this pictorial presentation, you will see like pain and thromboembolic events like pulmonary embolism contributing to this maternal mortality and morbidity cases. This is about the fetal outcome. And there's something called the iatrogenic prematurity. I'm glad I'm seeing some neonatal nurses here. Iatrogenic prematurity is something which can be prevented. When you look at our study, iatrogenic prematurity accounted for 70%, and other outcomes of fetal outcome was birth trauma. At discharge, this is an important event. At discharge, we had 4 clients who had died on maternal mortality, and 3 out of 4 women who died had no immediate complication after CS, while 1 experienced an immediate maternal outcome. So our study concluded that cesarean section can lead to poor maternal and fetal outcome. Therefore, cesarean section should only be performed when it's clearly advantageous. Fetal distress and previous cesarean section were the most common indication of cesarean section in both the fetus and the women respectively. And the iatrogenic prematurity was identified as one of the fetal outcome, and hemorrhage the most common maternal complication. So we recommend the primary cesarean section, which usually determines the future obstetric course of any woman, should be avoided whenever possible, and that is a role a nurse in MCH and even in labor can play. Then proper monitoring of labor. We are moving away from pathograph to labor care guide as per the World Health Organization recommendation, and this will prevent poor progress, which amounts to 15.1% of the indication of cesarean section. We want to encourage all hospitals to have a vaginal birth after cesarean section policy, or TOLAC, trial of labor after cesarean section policy or protocol that will guide women to avoid the cesarean section whenever possible. Then we recommend a further prospective study, because this is a study which was done on retrospectively. Thank you.